world. So Rushad is going to be talking about the silk route, the ocular surface and abrasion post-surgery. Over to you, Rushad.
Thank you, sir. So I'll try to also keep it a little brief because we are running short of time. So I'm going to be talking on the ocular surface and aberrations, our results with the silk platform. And what were the initial issues with lenticle surgeries? One was the caveat was that there was a slower visual recovery. This was due to various reasons. There could have been suboptimal laser energy delivery. Tissue manipulation used to be more Bowman's membrane microdistortions that we had published on. Centration was not very good. You had unwanted aberrations, you had decentered treatments, decrease in visual acuity because of this. You would have difficulty treating higher astigmatism in these patients. Another thing was LASIK surgeons were not well versed with lenticule at that time, and it required greater technical skill, a steeper learning curve, and the whole thought was if we can get this done more easily, why are we going through all this trouble? Toric alignment was also an issue initially with the older platforms, and of course things like dry eye, transient worsening of these symptoms. Now the ELITA, like Professor Mahipal has already mentioned, it's essentially a low energy treatment with a small spot size with contiguous spots. So what we found is that the dissection on the whole, and that's the key point in this, it's an easier dissection. It has a biconvex shape where the anterior and posterior surfaces are well matched, and the Bowman's distortions are minimized by this. There's also, as Dr. Shetty showed, less effect on the corneal nerves, and they're better preserved in this procedure. So we wanted to see what happens to our visual outcomes, quality of vision, and the ocular surface in this procedure. We looked at about 105 eyes. We did the dry eye evaluation in which we looked at Schirmer's, non-contact TBUT. With the keratograph, we looked at LipiView, the lipid layer thickness, and the OSDI questionnaire. We also looked at thermography, which is thermal profiling of the ocular surface. We looked at aberrations on the eye trace system, and we, of course, did our usual follow-up on the uncorrected and corrected visual acuities following the surgery. The standard inclusion and exclusion criteria were used. We treated up to an astigmatism of 2 diopters and a residual stromal bed thickness of keeping more than 300 microns. We excluded people with tear film abnormalities, anyone outside the range, any kind of retinal disorders, collagen vascular diseases, etc. Now, what is thermography? Because it's a newer concept that we've been working on. It is actually to look at the stability of the ocular surface. This is the device, which you can see, that small handy device in the top right screen over there. And it actually allows us to look at dynamic blinks and how those affect the ocular surface temperature. And we found that this correlates with symptomatology in dry eye patients, in computer users as well. So we looked at this specifically with regard to flap and flapless procedures as well. So coming to our results, we looked at efficacy and safety data. And what we found was that 95% of these eyes were 20/20 or better at 1 month. No patients lost 2 or more lines of visual acuity. One eye had a suction loss. That was a patient who moved the head quite a lot. So the main thing to remember is that the incidence of suction loss with this device, because of the tighter suction and the better suction that it maintains on the eye surface, is very, very low. And subsequently, we haven't had any other suction loss. There was one patient with a larger dark spot, had a lot more meibomian secretions, which had got plugged onto the patient interface, and no retained lenticule fragments were seen at the point of the study. Now, the accuracy of the MRSC, you can see the spherical equivalent attempted versus achieved. As Dr. Mahipal also mentioned, initially with the initial nomogram, there was a little bit of undercorrection, which was taken care of in the subsequent iterations. And the achieved spherical equivalent refractive accuracy within a 0.5 diopter was 81%, and within a diopter was 93%. This is all data from the autorefractometer, so there could be a little bit of a drawback due to that, but overall the visual acuities were very well maintained. Regarding astigmatic correction, again, it did well. Within a diopter of the intended treated astigmatism, we had 97% of eyes, and within a half a diopter, we had 75% of eyes. Now, looking at the wow effect of the platform, what we found was that including our initial eyes, which was our learning curve, there was a pretty good and a quick visual recovery on day 1. You had a logmar of 0.1 on day 1 and on 0.7 on day 7 that was well maintained. When we actually excluded the eyes, the initial learning curve eyes, that dropped down almost to 0. That means a 6/6 kind of vision on day 1 in 82% of eyes. So basically what we want to highlight with these slides is that the learning curve is reasonably quick in terms of ease of dissection, and therefore then the results tend to become better, faster in this. Now another concept we've been looking at is optical zones. We looked at both flap and flapless procedures with regard to the optical zones. And the next few slides, I'm just going to highlight what actually happens in refractive and especially in silk versus a LASIK treatment of a similar dioptric range. So you can see this is about a 4.25 with a 1 diopter cylinder. The effective optical zone, which is calculated by subtracting on the tangential map on the pentacam, you get this zone where there's less than a 0.5 change in the dioptric power and the tangential curvature. When we measured the horizontal and the vertical diameter, we had about 5.58 and 5.96. So the intended optical zone in this patient was 6 mm, you got about 5.77, which is a very good effective optical zone. For a similar spherical treatment in silk, which we did about a 5.75, we found a horizontal diameter of 5.66 and a vertical diameter of 5.21, still showing a very good effective optical zone of about 5.3. When you come to LASIK of similar treatments, what happens is that the effective optical zone tends to drop down. On average, you can see it's under 5 millimeters in these eyes. And that is an area where I feel lenticular extraction does score over LASIK for that particular region. Specifically with the silk platform, we've been getting pretty good maintenance of the effective optical zone. So why is it smaller in LASIK? There are various factors. There's biomechanics, wound healing, changes in curvature. There's loss of laser energy in the periphery in LASIK, which does not happen in lenticule platforms. The intrastromal ablation, there's more energy delivery, more inflammation, and therefore you can have, because of the inflammation, you can have the effective optical zone becoming smaller. Because this is a low energy treatment, specifically the silk platform is a low energy treatment, because of that you're mitigating the inflammatory effect and the stromal remodeling is less, and therefore you have a better maintenance of the effective optical zone. So this is our data on aberrations from the eye trace system. You can see post-operatively, spherical aberration does tend to decrease a little bit. And that is encouraging because generally you see aberrometry showing increases. Most of the aberrations did not show any significant change. The modulation transfer function, which is a function of our contrast, it did dip a little bit, but it was still above the cutoff of 40% at 10 cycles per degree. So it's showing that it's a well-maintained modulation transfer function or contrast activity as well. And these are graphs just representing our aberration profile. This is an actual example that we've taken from the eye trace, and you can see that there's a reduction in aberrations in this particular eye. This is again what I was talking about with regard to the MTF and the contrast. It stays reasonably well preserved, and you can see it's not dropping under that red box, which means that it's maintaining contrast reasonably well. Now looking at our dry eye data, we saw that the OSDI scoring did not show any significant change. The Schirmers did not show any significant change. Non-contact EBUT did not show any significant change. The lipid layer actually seemed to improve a bit. That is a little counterintuitive, but again, no decrease in the lipid layer. In terms of the thermography profile, we saw that the severity, compactness, and convexity of the ocular surface thermal profile did not show any change, meaning that silk does well in terms of maintaining dry eye parameters very well after the surgery. And this is again just a comparison showing what is happening to the thermal profile over a period of time in LASIK and silk, and showing that it basically does not change very much in the silk arm. So what we knew was that lenticular extraction procedures are safe and effective. However, learning curve and surgical challenges led to hesitation in adoption of the techniques. Issues with centration, toric alignment, older lenticule platforms did cause issues. With the ELITA platform, we found safe and effective treatment for myopia and myopic astigmatism. The recovery is reasonably fast with a reasonably good wow effect. There's a high degree of accuracy, minimal changes in aberrations and contrast sensitivity, and a minimal impact on the ocular surface. We have also published this paper, which is to try and help surgeons improve their learning curve. This is talking about the bubble sign which you get in the anterior plane. So if you're on the right plane of dissection, that bubble tends to collapse. So this is an intraoperative sign to guide whether you've inadvertently gone into the wrong plane, and therefore you can take corrective measures before you actually end up dissecting the entire posterior plane. So I would encourage you to read that paper if you can. It's freely available on the American Journal of Ophthalmology Case Reports website. And a big thank you to all our team at Shroff Eye Center, Dr. Apurva, Dr. Palak, who have been our fellows, Dr. Daryl, Dr. Ritu, and the entire cornea department at Shroff Eye Center.